In today's lecture, we're going to cover psychological disorders, a basic introduction to what it means to diagnose disorders, how to describe them, how we understand them, and so on. We'll cover some of the disorders in greater depth in future lectures. So Mark Summers, I'll put this link for you in the Reddit page for this lecture. Mark Summers, a former TV host, described his struggle with obsessive compulsive disorder in this fashion. I felt the need to clean my room, spent 4 to 5 hours at it. At the time I loved it, but then didn't want to do it anymore, but could not stop. The clothes hung about 2 fingers apart. I touched my bedroom wall before leaving the house. I had constant anxiety. I thought I might be nuts. This feeling of things not being the way that they should be, and always requiring this obsessive need for order is a hallmark of obsessive compulsive disorder. And so how prevalent is OCD as well as other disorders? How do these get developed? How do we know when there's something wrong perhaps with somebody? Again, we'll cover this in the duration of today's lecture. People are fascinated by the exceptional, the unusual, the abnormal. And this fascination with things that are different from ourselves can be due to 2 reasons. Number one, that during various moments we feel, think, and act like an abnormal individual. We all experience abnormality at some point within ourselves. Each person has this concept of who they are, of whether they're a mother, a son, a football player, a student, an athlete in general. However you describe yourself and who you are, we all have this kind of self-concept, but there are always moments that we kind of experience something that's outside of ourselves, and that can kind of throw us a little bit, and at the same time kind of get us a bit interested in others who may be experiencing that abnormality on a more consistent basis. Additionally, psychological disorders may bring unexplained physical symptoms. Sometimes you have these irrational fears or even suicidal thoughts. There are these thoughts and experiences that you have that under normal circumstances you may not even consider. Thinking about harming yourself, harming somebody else, being afraid of something that perhaps part of you may feel doesn't really make sense. We think about what Mark said about OCD. A lot of people who have OCD report feeling like something terrible is going to happen, something dreadful is going to happen if they don't hang their clothes in just a certain way, if they don't tap the wall a certain number of times before leaving the house. They'll go walking down the stairs to their car, and then they'll start thinking about whether they flicked the light switch on and off a certain number of times because according to some rule that they created. Again, this is kind of this there's this duality within a person that feels like often recognizing something could be wrong, but not really sure how to truly grapple with it. So we're often fascinated by these experiences and people who go through these experiences because on some level a lot of us can relate to that, having wishful thinking or thinking that you've got this lucky hat that you've got to wear to a football game because it seems like the team always wins and when you wear it, and so if you don't, is that going to be related to the team losing? It's kind of a more common but far extension of what somebody with OCD may experience. William James, the father of American psychology, said to study the abnormal is the best way of understanding the normal. That when we can explore kind of people on the fringe, we can learn more about ourselves at large. Sigmund Freud had a similar thought too, that essentially the unconscious mind, that which is deep within us that we can't consciously access, is more coarse, it's more obvious when people are experiencing disorders. That's when we start to see their unconscious kind of reaching out into the conscious landscape because it doesn't know how to live in a healthy way within ourselves. According to the World Health Organization, there are about 450 million people in the world who suffer from psychological disorders. It's a pretty significant number, but again, by no means any kind of majority. This is still less than about 10%. And depression and schizophrenia exist in all cultures of the world. Psychological disorders can often be very cultural bound, but there are some that we will still find across cultures regardless of what they value, what their day-to-day experience is like, and so on. Mental health workers view psychological disorders as being this experience of persistently harmful thoughts, feelings, and action. That they recognize that there's something harmful that's kind of steering us off course for our healthy living. Essentially, that when behavior is deviant, distressful, and dysfunctional, psychiatrists and psychologists label it as disordered. I've got a little box on the next slide that further illustrates some of these qualities. So this may be a little difficult to understand, so let me walk you through it. Regarding statistical infrequency, if something is statistically infrequent in the normal population, somebody in the abnormal population would experience that much more frequently. So believing that others are plotting against you. In a normal population, that kind of thinking is very rare. Not many people think about it, but maybe from time to time, you're in school and you're thinking about your teacher. Seems like that everybody is kind of giving you a similar grade despite trying to work hard in one area or being interested in a particular subject and thinking you've really got it. Maybe that thought will kind of come and go over the course of a day or two, but in the long run, very rare do you think about that. But compared to somebody in the abnormal population, that may really be weighing on them, and they may see that in their teachers, their coaches, their friends, their parents, that this thing that occurs normally very infrequently is instead very common with somebody who is struggling with a disorder. We've also got disability and dysfunction. So for example, being unable to go to work due to alcohol abuse. If this dysfunction or disability is occurring very frequently and has a great level of dysfunction, that is again going to be considered abnormal and troublesome. Having one or two hangovers a year where it's just a little tougher to go to work, perhaps. Again, totally normal. At least it's not anything to necessarily be too concerned about, especially if you still make it through work and you do an alright job. But somebody who struggles every single day, or even takes several days off every couple of months just because they need to recover and they're just getting into the drinking so much. Again, we're kind of looking on this continuum. Where would you be placed in terms of your level of dysfunction with your psychological issues? Personal distress, for example, having thoughts of suicide, that is extremely distressful. People don't like the thought of wanting to kill themselves. So experiencing that high level of distress, we would still consider to be abnormal. Having these thoughts come up that are constantly stressing you out and really paralyzing your ability to function is absolutely something that needs to be addressed immediately. On the flip side, personal distress thoughts that just cause like a little bit of distress might be worrying about a homework assignment you hand in, or worrying about whether you'll get to see go to see a movie this weekend, or if you'll just be home alone on Reddit all day. Might cause a little bit of distress, but you kind of get over it, or you kind of maybe easily think of ways around it and to kind of grapple with it. That would be on the low end, kind of the normal population side of things. And lastly, violation of norms, like shouting at strangers. That our society has these kind of unspoken rules of how we should act around one another. And a person who is very frequently violating these social norms, we would consider to be abnormal. Whereas somebody who does not shout at strangers very often at all, we would place in kind of the normal population. So again, considering these different factors, all these different continuums, where would we kind of place an X on each of these to place somebody in terms of their statistical infrequency, their level of disability or dysfunction, the personal distress, and violation of norms? How much are their behaviors, their thoughts, their feelings impacting their ability to function and live a roughly stress-free life? So deviant behavior in one culture may be considered normal in others, but it may lead to arrest. And deviant behavior must accompany distress. That it's this kind of, again, social dictation of what is considered deviant that that people must adhere to in terms of not doing those behaviors. If the behavior is dysfunctional, it is clearly a disorder. If it prevents somebody's ability to function in their day-to-day life, in their work, in their home environment, in their relationships, if it's causing disruption in their ability to function in their day-to-day lives, it is definitely a disorder. This is the easiest kind of way to kind of peg if somebody is suffering from a psychological disorder. Now, there are some culture general symptoms, essentially some symptoms that are shared across culture. And I know some of you, again, listen to this instead of watching it, so I'll quickly kind of run through some of them. So being nervous, feeling apart or alone, worrying all the time, not getting along with others, feeling restless, feeling hot all over, being in low spirits, having trouble sleeping, feeling like you can't do anything worthwhile, like you're lacking meaning. These are some of the culture general symptoms that we can find throughout the world, regardless of your background. So there definitely exists kind of a set of symptoms where regardless of where you're from, if you experience any of these, that begins to show some level of disordered living. And again, the degree to which, how it's affecting you, the duration, all that stuff all comes into play. But in general, if somebody can't get along with other people, hardly at all, it doesn't matter where you're from, people all around the world view that as being an issue. Now, there are some culture-bound symptoms where there are unique symptoms that differ across cultures. So, for example, in West Africa, there's this disorder called brain fog, or kind of this symptom of brain fog. It's experienced as brain tiredness, a mental and physical response to the challenges of schooling. And when you go to school very frequently and you're trying to grapple with the day's learning activities, kids can experience this brain fog of kind of getting too mentally tired, and that's a symptom. That's a problem that needs to be addressed. In the United States and in other cultures of the world, this is not necessarily a labeled symptom. At least it's not labeled as brain fog. We may call it something else or include some other symptoms to kind of piece together this experience that would be a disorder. But again, something unique to West Africa, just as an example. And there's some others too here. You feel free to pause the video and take a look at them regarding something that's more Western bound, anorexia nervosa, severe loss of weight resulting from self-imposed starvation, and obsessive fear of obesity. That's huge in Western culture that we just don't see in many other cultures. Some ancient treatments of psych disorders, so how they would actually fix or at least attempt to fix some of these problems, would include trephination, which is boring holes into the skull to remove evil forces, exorcism, being caged like animals, being beaten, burned, castrated, mutilated, and transfused with animal's blood even. Again, we're talking hundreds of years ago, that if somebody was experiencing psychological issues, there would be any number of fun treatments to go through to try to release some of these evil spirits and to get these demonic forces out of oneself. Pretty interesting that where things were a couple hundred years ago and how they've developed to today's treatments. Philippe Pinel from France insisted that madness was not due to demonic possession, there's a concept, but an ailment of the mind, that there's more to it than just kind of these evil forces within us, but rather that it's something that's kind of perhaps with our brain or our mind, our natural essence of self and who we are as people, rather than, again, these kind of strange otherworldly forces going on. When physicians discovered that syphilis led to mental disorders, this is a huge breakthrough. The medical model started looking at physical causes of these disorders. So, for example, the etiology. We would be concerned with the causation and development of the disorder. How did it come about? Where does it stem from? And this can help us in terms of preventative work in the future. If we know how it begins, it may be possible for us to develop some ways to prevent it from even occurring in the first place. Diagnosis. This is when we identify and distinguish from one disease to another. when we can say that there are these kinds of diseases or these kinds of disorders that contain X, Y, and Z symptoms that's necessarily different from this disorder that has A, B, and C symptoms. Once we can begin to accurately diagnose things similar to a medical model, we can start developing treatments that are fine-tuned for exactly that disorder. Because again, next up, treatment. This is when we can treat a disorder in a psychiatric hospital using medical means or psychotherapy or group work, all kinds of different methods. Prognosis, this is when we can forecast about the disorder and make a prediction based on statistical data, data coming from the patient or client, depending on which term you prefer, that we can start to describe what the person's experience will likely be in the future. We're can't do it 100% accurately, but again, kind of using the information we have at our disposal to make prognosis. This is all based on the medical model of psychological disorders. Now, modern psychology has adds still yet a bit more to it. Includes 7 major perspectives on abnormal behavior. We've got the cognitive model, for example, which is essentially describing faulty thinking. The way that you perceive the world, the way that you think about the world is faulty. It's inaccurate, or it's unreliable, it's invalid. There's something about it that's just not working right, and so we need to work on that level of thinking within you. Biological, again, something with brain function, maybe you have a genetic predisposition, something about your biochemistry is out of whack, and that could lead to abnormal behavior. Sociocultural, there can be problems even within cultural values and beliefs and how you align with or don't align with particular cultures and subcultures and whatnot. That the influence of people around you could be leading to abnormal behavior. Behavioral could be inappropriate conditioning or modeling when people show you that this is how we act around one another. If you were raised by abusive parents, again, this isn't a one-to-one ratio of everybody raised by abusive parents comes out abusive themselves, but there are some people who could learn that and say, well, this is how you deal with kids. My parents, raised me in such a way where hitting was fine and it kept me in line, so that's going to be helpful too, and I'm going to do that to my child. In today's environment, we don't value corporal punishment and physical punishment with children, at least in the United States, and this would be considered abnormal behavior if we became aware of really extreme, especially abusive behaviors on children. But again, that could be conditioned or modeled through the parents, showing that this is what you do, and later again develops into abnormal behavior when the child becomes a parent themselves. Regarding evolutionary psychology, having this understanding that there's this exaggerated form of an adaptive reaction, that people naturally develop these adaptive methods to react to the environment, and that perhaps somebody is developing it more rapidly or kind of more extreme, and thus is acting in kind of an abnormal way. On the humanistic side of things, something that I personally align with myself as a theorist, that there's this idea of blocked personal growth, where we're all striving as people to be better and to grow and to be to reach our fullest potential of who our self-concept person is. And when we experience and our experience of disorders is communicating that our personal growth is being blocked, that we're not able to become that which we ideally wish to become, and this stress of me not being who I want to be is going to cause a lot of abnormal symptoms, a lot of abnormal behaviors. And lastly, psychoanalytic or psychodynamic approach. This is traditionally aligned with Sigmund Freud and his method of clinical psychology, but has since developed well beyond Freudian thinking into a way of thinking that's much more accepted and much more even helpful today in the treatment and conceptualization of disorders. But basically, it's that this unconscious, our unconscious mind is being disrupted. That in terms of its ability to function within the world, that there's this unresolved conflict that is holding us to a more primitive way of functioning, more primitive way of understanding the world, and behaving in the world, and that this unresolved conflict, again, is leading to abnormal behavior. So regarding kind of the more practical side of things, the DSM-4 was developed by the American Psychiatric Association, and this was used to describe psychological disorders. And the most recent edition, the DSM-4 text revision from 2000, describes about 400 psychological disorders compared to 60 in the 1950s. And the DSM-5, in very recent news, has just been approved by the APA and will be published, I believe, in May of 2013. And there have been some significant changes that have got some people very excited and other people very scared and worried. And I'll touch on that just briefly in a short while. But the DSM-4 right now, and soon coming the DSM-5, is kind of the Bible of psychology, at least of clinical psychology and abnormal psychology, as it describes all the disorders in detail. And clinical psychologists use a multiaxial classification. On the first axis, we want to know, is it a clinical syndrome? Is there a cognitive dysfunction? Is there anxiety? Or is it a mood disorder? What exactly is present in terms of it being a sort of clinical experience, a clinically diagnosable disorder? On axis 2, it's kind of difficult to differentiate between axis 1 and 2 if you've not worked with populations that would regularly have these kind of clear diagnoses. But axis 2 is primarily concerned with personality disorders or mental retardation. Axis 2 is the general kind of difference between 1 and 2 is that 2 can last essentially a lifetime and has generally poor prognosis of successful treatment. It's not to say that it's impossible, at least with personality disorders. We can't say that it's impossible to overcome them or anything, but we look at something on axis 1 as more often being a bit more temporary, that it could last weeks, months, could last years, but axis 2 almost definitely lasts years. It often goes years being untreated, or again will last a lifetime. This is something that permeates more of the person's overall existence on axis 2 rather than axis 1 being just kind of a more specific issue. Axis 3 is concerned mostly with general medical conditions. That is it diabetes, hypertension, arthritis, etc. This is usually diagnosed by a physician. Axis 4, are there any psychosocial or environmental problems, any school or housing issues, relationship issues, things like that are present. These are while there are some kind of clear categories to mention, they're more kind of spelled out by the psychologist, so they are not necessarily like a certain kind of disorder that falls under axis 4. It's more of a description of the current psychosocial or environmental conditions. And lastly, axis 5, the global assessment of functioning, the GAF score, describes, it assigns a numerical value to the person's level of functioning from 0 to 100, with much of the normal population kind of floating in the 80s and 90s, maybe in the high 70s, but kind of in that 70 range, we begin to see disorders and symptoms becoming pretty disruptive, and then of course on downward getting progressively worse as the score goes down. So the goal of the DSM is to first describe the orders, and then second indicate the prevalence of the disorder. All that information is found within it. The disorders outlined by the DSM-4 are reliable, and thus diagnosis by different professionals are similar. Whether you see a psychiatrist or a psychologist or a clinical social worker or any other kind of clinician working in mental health, if they're referencing the DSM-4, they're going to be able to make generally reliable diagnoses. There's always room for differences of opinion and whatnot, especially when some disorders share a lot of similar symptomatology. But in general, the DSM-4 is provided as a sort of guide, so that as we begin to learn of a person's symptomatology, we can use it to kind of form a constellation and make sense of what the disorder is, and thus several people can agree upon yes, we can see these symptoms lining up to present as major depressive disorder, for example. However, others criticize it for putting essentially any kind of behavior within the compass of psychiatry. That when we look at the difference between 50 or 60 disorders to 400 disorders over the period of several decades, that certainly does seem a little fishy when nearly any kind of behavior can be found within the book nowadays. But again, they're always revising and always trying to be more clear on what exactly is disordered behavior versus what is not. Every revision of this text seeks to try to refine the understanding of abnormal behaviors among clinical psychologists and other similar mental health workers. So some critics of the DSM-4 also argue that labels can stigmatize individuals, that somebody, once they get a diagnosis of OCD, that they kind of wear that as a stamp on their head, that I've got OCD and that's my problem, or I've got ADHD and that's my problem, and whatnot. That it all of a sudden puts those people into certain categories and says, now this is how you're expected to function, and when people know that, it can stigmatize them and prevent them from being viewed any other way. We think back to Mark Summers at the beginning of this lecture, and think about if his OCD was very widely known, especially in the public eye, being that he was a television host, that if that was one of those things that everybody knew about him, or even if he chose to make mention of it, people could be looking for that kind of behavior in the shows that he's hosting, in his desire to make things even and symmetrical, and to have all these rules of how he should be living. And it would be very difficult for us to ever believe that Mark Summers could possibly function without these OCD behaviors. That putting these labels on a person in the first place greatly limits their potential to live in a healthy way. That is a very legitimate criticism of labeling systems such as that found within the DSM. However, labels can be helpful for healthcare workers in a sense that when we can communicate with one another and discuss therapy options, it's a lot easier for us to say the client has borderline personality disorder and generalized anxiety disorder, and here's what we're using to treat the generalized anxiety disorder, here's what we're using to treat borderline personality disorder. That as we use the names and discuss treatment options, we can much more easily communicate about people and their struggles, as well as develop treatment methods. For example, something designed specifically for generalized anxiety disorder may not do well with diagnosis of schizophrenia. But as we're developing these treatments, we can say and focus on that this is specifically for this disorder and not necessarily for other things. That it's the therapy in general can treat a lot of different disorders, but a very specific approach to therapy is not necessarily going to help every disorder. So we need to be able to understand what's ruled in, what's ruled out, what are these categories, and to be able to communicate with one another about these disorders. Additionally, insanity labels raise moral and ethical questions about how society should treat people who have disorders and have committed crimes. Do we excuse people just because they've received that label of insanity, that they weren't able to control themselves, and thus I'm sure if they were of sound mental state that they would not have chosen to commit these crimes. What does that say about our understanding of people and their actions and how they behave in the day-to-day world, especially when it involves committing such heinous crimes? Now, regarding rates of psychological disorders, you can see it ranges very, very widely, as low as 1% on schizophrenia to as high as almost 8% with phobias of any kind, being afraid of spiders or heights or what have you, or clowns. And that a lot of people experience disorders 2 at a time or 3 at a time, that depression and anxiety can be found simultaneously, or an alcohol abuse problem can be found simultaneously with an anxiety disorder. And so this all fits under the same umbrella of just any kind of mental disorder at all. Seems like a pretty high prevalency rate, but again, it's very accurate in terms of how it represents the world population, and how we understand deviant behavior, dysfunctional behavior, statistical infrequencies, and so on. And lastly, with regard to psychological disorders, having occurred at all within the previous year, based on the countries sampled, United States very, very high of just any mental disorder at all. Again, could be mild depression, could be a little bit of anxiety, as long as it can be diagnosed. Even if the seriousness of it is relatively mild, that would still fall under that blue bar of just any mental disorder. But serious mental disorders, you can see a little bit more variance. Still very high for the United States, but it kind of bounces up and down as we look at different countries. So again, United States, it's very high, and it's a bit, all of us are very curious then of why that is. Are we perhaps more accurate in how we diagnose people, and thus we understand that more people have disorders than we think? Or are we being inaccurate in terms of it being a capitalist society and saying, well, we need to keep the lights on, we got to keep the doors open here, and so we've got to make sure that we treat as many people as possible, and increase our billable hours and whatnot, and that shoots the bar sky high. A lot of different factors into this, but it's still interesting to note the differences of mental disorder prevalence and serious mental disorder prevalence across the world. So our next lecture will cover depression and anxiety as specific disorders. They're categories, but we'll look a bit more in depth into those in our next lecture. So look forward to that. And until then, I will see you next time.